I would like to start out by thanking AstraZeneca for their generous sponsorship that makes this program possible tonight. So we know what you're all here for. You're wanting to hear about the latest treatments in metastatic breast cancer. So without further delay, I just want to tell you a little bit about our speaker this evening, Dr. Nancy Lin. Dr. Lin is the Associate Chief Director of the Division of Breast Oncology and Director of the Metastatic Breast Cancer Program at Dana-Farber Cancer Institute, and she is an Associate Professor of Medicine at Harvard Medical School. Her research is focused on developing new treatments for people with metastatic breast cancer and in understanding what causes treatment resistance in metastatic disease. To read more about Dr. Lin, I encourage you to go to lbbc.org for her bio. With that, I would like to thank Dr. Lin for being with us and turn things over to you for a short presentation.
Great. Thank you so much. And thank you to everyone at LBBC for putting this together and all the work that you do all year long. All right. So today I'm going to give an update on metastatic breast cancer treatment circa 2020, understanding that things are changing very rapidly. And I think that in 2021, we'll see even more treatments on these slides. So I wanted to set the stage by first just reviewing breast cancer subtypes, and many of you already know what your breast cancer subtype is, but if you don't, it's important to talk to your doctor and ask what type of breast cancer you have, because more and more this really determines the kinds of treatments that we consider in patients, and it would help also if you're interested in clinical trials to understand which trials you might qualify for. So the three major subtypes we think of are estrogen receptor positive, or sometimes called hormone receptor positive breast cancer. And this is breast cancer that is positive for either the estrogen receptor or the progesterone receptor. And so it's sensitive to female hormones, and it's also HER2 negative. The second subtype we think about is HER2 positive breast cancer. So HER2 positive breast cancer is cancer that has a lot of this marker called HER2 on the cell surface. And it can be either estrogen receptor positive or negative. And finally, what we call triple negative breast cancer, which is negative for the three common markers we look at in breast cancer, hence the name triple negative, and that's estrogen receptor negative, progesterone receptor negative, and HER2 negative. And on the left, you can see the breakdown of the subtypes, so that estrogen receptor positive is the most common, and HER2 positive and triple negative, depending on the study that you look at, make up around 15% for triple negative and probably somewhere around 15 to 20% for HER2 positive. So where are we now in 2020? And I think that we have a better understanding of breast cancer subtypes. There are many more treatments available than there were even 5 or certainly 10 years ago. I hope that we pay more attention to quality of life. We have more options in terms of symptom management, mental health, and also really, I think, hopefully more attention paid to the holistic aspects of care. And this has led to longer and better survival in many patients, although obviously we still want to do better. One of the things I think is important to lay the groundwork for, and we'll get into some of these details, I'm sure later in the Q&A, is what sort of testing can be helpful. And I think it can be a little bit confusing because lots of different words are thrown out. The basic testing that we do for all breast cancer are these three markers, as you heard about: estrogen receptor, progesterone receptor, and HER2. And that testing is done on the tumor tissue, either a biopsy or surgical sample. And it really is the most important test that we do because it determines the tumor subtype, and that in turn identifies the best treatments. But there are other tests that we do. We do what's called germline genetic testing. So that's testing to see whether or not you have an inherited reason or explanation for breast cancer. And that can be done either on blood or saliva. And we do that testing not only to help family members understand their cancer risk and for individual patients to understand their cancer risks, but also because patients who have inherited BRCA1 or BRCA2 mutations may benefit from a group of medicines called PARP inhibitors, which are these oral medicines that, as it turns out, works in general on average better than chemotherapy. And actually now we have data for one of the other inherited mutations called PALB2, that patients who have this mutation may also benefit from PARP inhibitors. Some of you may have had what we call somatic gene testing or next generation sequencing. This is done on tumor tissue. Some of the companies that do this are Foundation Medicine or Guardant. There's a bunch of different companies that do the testing. And we do this because there are some alterations that can determine treatment, including mutations in this gene called PIK3CA, which is associated with an FDA-approved treatment called Piqray. We look for what's called microsatellite instability. It's really uncommon in breast cancer, but it is present sometimes. And there is an FDA approval to give immunotherapy in patients who have this marker. And then there's a whole series of different changes that we can see on this testing that might help people match for clinical trials. Now, in some patients, it's not possible to do a biopsy, or it's not safe, or maybe it's just not in a convenient location. And there is now technology for what's called blood biopsies, where many of the same mutations and gene changes actually can be determined using a blood sample rather than a more invasive biopsy. There's still some things that a blood biopsy can't do, like ER, PR, and HER2 testing. It's not as reliable with a blood biopsy as it is with actual tumor tissue testing, but for many of the mutations, it is quite reliable, especially if it's drawn at a time when your cancer is worsening, which is when it is most likely to pick up something. So I'm going to just go in a few minutes on how, in general, we treat people who have estrogen receptor positive metastatic breast cancer, and then I'll show similar slides for the other subtypes. And again, just to stress, these are general guidelines. So everybody has different circumstances, and obviously there could be reasons why you might do things in a different order, but just to give a general sense of how an average person might go through the various treatments. The first treatment most typically would include hormonal therapy with a so-called CDK4/6 inhibitor. It's a targeted treatment that works in combination with hormonal therapy. And the three medicines that we use most commonly are Verzenio, Ibrance, and Kisqali. Sometimes we do start with chemotherapy. That's kind of unusual. There often are particular circumstances. For example, somebody who has very rapidly worsening cancer. But most of the time, we're going to start with hormonal therapy and a CDK4/6 inhibitor. As we move down the lines of treatment, it becomes more different from one person to another. And much of it depends on your individual tumor characteristics, as well as the time course of your cancer. So for many patients, the next treatment is going to be some sort of hormonal treatment, and that could be hormonal treatment on its own, or hormonal treatment with either Piqray if your cancer has a PIK3CA mutation, or a medicine called Afinitor if your cancer doesn't have a PIK3CA mutation. Again, if we know that the cancer has a BRCA, if you've inherited a BRCA1 or 2 mutation, we might consider a PARP inhibitor. And in some circumstances, we may consider chemotherapy rather than going to hormonal therapy next. And then as the third, fourth, fifth, et cetera, treatment, a lot of it, again, depends on the previous response to hormonal therapy. But in many cases, this is when we start thinking about chemotherapy. For HER2 positive breast cancer, the treatment algorithm is a little bit more straightforward, and most patients end up moving through this algorithm. As our first treatment, we typically give chemotherapy, whether it's Taxol or Taxotere or Abraxane, some sort of taxane, together with Herceptin and Perjeta, which are targeted medicines against the HER2. That is what causes HER2 positive breast cancer. As the second treatment, when that first treatment stops working, we usually go to Kadcyla, otherwise known as TDM1. And then as the third or the fourth treatment, we'll typically go to either the combination of 2 pills, Tukysa and Xeloda, with IV Herceptin, or we will choose IV trastuzumab deruxtecan, which is also called Enhertu. And whichever one we didn't do third, we do fourth. And then from the fifth treatment line on, there's a lot of different Herceptin plus chemotherapy combinations that we typically give. And as you can see, there's a lot of different combinations that we can go through over time. And then finally, for triple negative breast cancer, this is where even 5 years ago, the algorithm would have been chemotherapy, 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 but now has really changed. as a result of some clinical trials that have reported out over the last 2 years. So as the first treatment, the important marker that we test for is something called PD-L1. And this marker helps us determine whether your cancer will be responsive to immunotherapy. And in fact, clinical trials have shown that in people who have PD-L1 positive cancer, adding immunotherapy to chemotherapy improves the length of survival. So if you have a cancer that's PD-L1 positive, typically we'll start with chemotherapy plus immunotherapy. If your cancer is PD-L1 negative, we'll typically start with chemotherapy. And the exception to that is that if you have a cancer, if you've inherited a BRCA1 or 2 mutation, we'll typically start with a PARP inhibitor. As the second treatment, again, we typically go to chemotherapy. And the exception is if one has a known BRCA mutation and has not previously received a PARP inhibitor, we would often give a PARP inhibitor. And then in the third third line or the third type of treatment, it used to be kind of all sorts of different chemotherapies were considered in that situation. But now I think most would, for many patients, choose Trodelvy or sacituzumab, which is a new drug that was recently approved by the FDA for triple-negative breast cancer patients. I want to just highlight a couple of things that are in the future, to sort of have them out there. I know this presentation will be made available later, so I don't you don't have to like scribble all of these notes down. But I think it's just good to sort of know what to look out for and what are the kinds of drugs that are, getting close to potential FDA approvals. There's a group of medicines called antibody drug conjugates, and in the next slide, I'll show you what they do and why we call them that. But in HER2, which is already approved for HER2 positive breast cancer patients, it's in a phase 3 trial for patients who have what's called HER2 low cancer. So that's cancer that is by usual criteria HER2 negative, but still has a little bit of HER2 on the surface. So we're waiting for the results of that trial, and we think that they will be available sometime in 2021. Similarly, there's a phase 3 trial of Trodelvy, the medicine that was just approved for triple negative breast cancer in patients who have estrogen receptor positive breast cancer. And again, we hope that we'll see the phase 3 results sometime in 2021. And then there's a number of other antibody drug conjugates that are looking really promising in clinical trials. And they right now have mostly like numbers and letters. But I think some of these are quite likely to move into the phase 3 setting. And so it's worth looking out for. There are some new hormonal treatments that are being developed. Some of them have made it to phase 3 trials. Many of them are still in phase 1. But they go by these acronyms, SERDs. So SERD is a type of medicine that helps to cause the estrogen receptor to be broken down by the cell. It's similar to Faslodex, which those of you who have hormone receptor positive breast cancer may have already received. But these are oral medicines, and so they're more convenient than Faslodex injections, and it allows us to get up to higher doses, and also has some properties that Faslodex does not have. And similarly, there are other new types of medicines to attack the hormonal system, including something called Serans and Protex. But I think that some of these will likely get pretty far in terms of clinical trials. There are new targets being discovered every day and new treatments to try to aim at those targets. There are ways to try to better utilize immunotherapy, because right now the only place that immunotherapy has an FDA approval is in the small group of patients who have PD-L1 positive triple negative breast cancer. And we think that immunotherapy could be effective in other subtypes of breast cancer, but we haven't quite figured out how to make them work optimally. And finally, although it's not necessarily in vogue these days, with the advent of so many targeted therapies, we still need new chemotherapies. And so there are actually 2 chemotherapies that will go to FDA for review in 2021. I listed one of them here, which is called Tezitaxel. It's an oral version of Taxol that is taken as a couple of pills once every 3 weeks. And so there was a phase 3 trial that was just reported at our annual San Antonio meeting. and that should go to the FDA for review sometime in 2021. And there's another oral Taxol, which is basically Taxol plus this other medicine that helps it absorb. That combination pill is also slated to go to the FDA sometime around February of 2021. So these are all really on the relatively near horizon. I just want to tell you a little bit about what antibody drug conjugates are, because we already use them routinely in people with HER2-positive breast cancer. We now have Trodelvy for people with triple-negative breast cancer, and as I told you, there are 2 phase 3 trials of antibody drug conjugates in people with estrogen receptor-positive breast cancer. So I think very soon we'll probably be using these kinds of drugs across all types of metastatic breast cancer. So on the left is a picture of an antibody. An antibody is a Y-shaped protein or molecule that people's bodies naturally produce, and they produce them against viruses and bacteria. But in this case, they can be engineered to actually find its way to any target that we want. And then you can actually attach chemotherapy to this. And so on the right is a picture of a cell. So you can see the antibody with the chemo sort of attached to it. The blue triangles are whatever target we might pick. So it could be HER2 in the case of in the case of Kadcyla. It could be something called TROP2 in the case of Trodelvy. And basically what happens is that the antibody finds its way to the target. The cell essentially swallows the complex, and then the chemotherapy is given in a very high concentration in the cancer cell. And because many of these markers on the surface are highly expressed, meaning there's high levels on cancer cells, but lower levels on normal cells, it allows us to actually target the chemo more effectively to the cancer cells. The final few comments I have before we go to Q&A is just a few comments about clinical trials. So clinical trials are available along many points in time. I think it's a common misconception to think that clinical trials are only as the last resort or when there's nothing left to try. But in fact, more and more there are clinical trials as the first treatment, second treatment, third treatment, et cetera. And there are trials where it has to be that you get it as the first, second, third, et cetera treatment. And if you wait until you've had 10 treatments, then you don't qualify. So I think it's important, if you are interested in clinical trials, to let your oncologist know. Sometimes people make assumptions that are not true. They might say, oh, she has a couple of young kids and might not want to travel. And people make assumptions sometimes. And if you are interested in clinical trials, it's really important to sort of verbalize to your oncologist that you really are interested and you want to know about what's available. You can consider a second opinion in an academic medical center. And then I'll show you on the next slide some trial matching websites. So this is from the LBBC website, and there's a really nice resource about clinical trials and what they mean and what's involved in participating in clinical trials. And then as part of this website, you can link into what's called the metastatic breast cancer trial search. And with some information about the type of breast cancer that you have, and there's a little way to show how far you're willing to travel, the website can actually then spit out for you a list of potential clinical trials. And then this is something that you can bring to your doctor and help winnow down the list to the things that would be most of interest to you and that you potentially could qualify for. So that's all I have for the main slides, and I think we're ready to turn it over to Q&A.
Thank you so much, Dr. Lin. You really covered an awful lot in a short time. So thank you for that really comprehensive introduction to the most contemporary treatments in metastatic breast cancer. And I want to thank all of the participants. We've already got a number of really good questions. So I'm going to start with one that's being asked by a number of different people in different ways, Dr. Lin, which is what can people do if they have a progression after receiving a CDK4/6 inhibitor? Can they try another one? What are some other options for them after they experience a progression with that?
Right. So that's a really good question, and it's a question that I wish I had a definitive answer for, but what I can tell you, there's a lot of research going on. I mean, one of the questions that we don't have the answer to right now that I think is really important is there a value in continuing a CDK4/6 inhibitor after you've had one? So like if you had Ibrance, does it make sense to switch over to Verzenio? And another important question is, does it make sense to switch out the hormonal therapy? Like, can you get more mileage by, let's suppose you're on Femara and Ibrance? Is there any value in continuing the Ibrance and actually just switching over to Faslodex? So there are some clinical trials that are ongoing to like definitively try to answer these questions. One is being led by my colleague, Dr. Erica Mayer. It's called the PACE trial. But there are other clinical trials that are looking at this as well. In real life, if a patient does not qualify for the PACE or some of the other trials, depending on the situation, I will talk about it with patients. And it sort of depends on the situation. So if somebody, starts on let's say, Ibrance and letrozole, and their first scan in 3 months looks worse, I'm not going to go around switching around the CDK4/6 inhibitor because I think that is unlikely to be helpful. But there are people who are on for 2 years and then like one little area gets a little bit worse. And you sort of hate to give up the benefit that people have gotten. And that's the situation where I might, either switch out the hormone or switch out the CDK4. I tell people that we don't have definitive data that that's helpful, but that would be a situation I might talk about it with patients. But what I hope in the long run is that we really definitively answer the question for people. The other thing that I think is important is that we're learning more and more that when people's cancers become resistant to CDK4/6 inhibitors, it can happen a bunch of different ways. It can happen because the estrogen receptor gets mutated. It could happen because it picks up a HER2 mutation, even though the cancer is HER2 negative. And one of the ways that we can understand what's going on actually is either to do either a regular biopsy or a blood biopsy. And then if we were to find, for example, a HER2 mutation, these are quite rare. There's less than 5% of patients with HER2 negative breast cancer will have a HER2 mutation, but they do come up. And there's a couple of national clinical trials to actually look at HER2 treatments for HER2 negative but HER2 mutated breast cancer. And one of those combinations was just presented at the San Antonio meeting. It's neratinib, Herceptin, and Faslodex. And they reported that almost 50% of people had tumor shrinkage, actually, who had HER2 negative cancer who just had a mutation. So I think that, more and more we're hoping that by testing cancers or testing people's cancers, at these various points in time, that we may pick up these things they're not very common. But if we picked it up and we were it's able to lead to a treatment, I think that there's value in that.
Thanks, Dr. Lin. I want to follow up with, there's a couple of folks who are asking about differences between hereditary gene testing and genomic sequencing that you were talking about. Can you just explain the differences between them and then how often you recommend people get genomic sequencing for the tumor?
Yeah, so really good question. It's confusing because we use similar words, but I think of genetic testing or germline genetic testing as it's usually from blood or saliva, and it's really looking at inherited genes. So like, did you inherit a gene from your mom or your dad that is associated with breast cancer? And the classic genes that we think about are like BRCA1 and BRCA2. Genomic testing or sometimes known as next generation sequencing or tumor testing, that is actually testing the genes in the cancer, which are not the same as the genes that you inherited. So you can end up developing mutations in genes that you inherited perfectly normal copies of, but they became mutated in the cancer. And so an example of that would be something like PIK3CA, which is a gene that's mutated in about 30% of estrogen receptor positive breast cancers. In general, the type of breast cancer where the tumor sequencing or genomic testing is most likely to lead to some treatment is an estrogen receptor positive HER2 negative breast cancer. So for patients who have that type of breast cancer, I routinely order it on essentially everyone at least once. For patients who have HER2 positive breast cancer, as you saw from the slides, the algorithm is kind of pretty fixed. It's not really that dependent on the genes. So I might order it if I'm running out of ideas, or I might order it as part of research study, but in general, it's not going to help that much. And for triple negative breast cancer, the most important marker at this point is PD-L1, which we don't get from the genomic sequencing. It's actually a test on the biopsy. But I do sometimes order it because I'm really looking in that case for clinical trials.
So one of the questions that we got actually about clinical trials, since we're talking about that, is that if you are receiving a treatment that's working for you, is there a reason that you should think about or pursue a clinical trial?
Right. So in general, the vast majority of clinical trials enroll patients whose cancers are worsening, and then you go right onto the trial. So if your cancer is responding, you're not able to go on the trial because whatever treatment you're on is working, and we don't necessarily want to rock the boat because we don't know whether the trial treatment will be better than your current treatment. There are a couple of exceptions. So for example, there is an ongoing trial called PATINA, P-A-T-I-N-A. It's actually testing CDK4/6 inhibitors in people who have HER2 positive breast cancer, the group we don't normally give CDK4/6 inhibitors to. And in that trial, what happens is the people who are finishing up with chemo, Herceptin, and Perjeta, so like Taxol, Herceptin, Perjeta would be a common regimen, and they are ready to go on to just get Herceptin, Perjeta, and drop the chemo, which we usually do after a couple of months, can go on the study. They continue Herceptin and Perjeta, they continue hormonal therapy because this is for estrogen positive, HER2 positive breast cancer, and then in a randomized way either get the CDK4/6 inhibitor or not. So that study is one of the more unusual studies where it's actually looking for people who are doing well on their current regimen, but most studies are in patients whose cancers are worsening. Still, I think that there is, if you are interested in trials, it's often very valuable to actually meet with a doctor who is at a center which enrolls to clinical trials or has a lot of clinical trials open, even when you're doing fine, because it's kind of a less pressured environment and situation. You don't need to start your treatment right away, your next treatment. You can take the time to meet a new person, decide if you like them. There may be additional tests that they run on your tumor to sort of get ducks in order for the next time your cancer worsens. And so I think oftentimes it's helpful to seek out a second opinion even when you're doing well, because it's more of kind of getting plugged into a system. And it's not necessarily an academic medical center. There are a number of community sites who are very active in clinical trials. So it's really about seeking out a place that tends to open a lot of trials.
Thanks for answering that. So sort of as a follow-up to that one, we have a participant who has metastatic HER2 positive disease and has been taking Herceptin for more than 8 years. And she's asking, how long is it possible to stay on Herceptin? Or you could also speak broadly about how long is it possible if a treatment's working for you, how long can you take it?
Yeah, so, this is so first of all, I'm so happy to hear that you're doing well. And, if we look at there's a clinical trial called Cleopatra where people got Taxol, Herceptin, Perjeta, and then after 6 to 8 rounds worth of chemo, they just got Herceptin and Perjeta. And we have very long-term follow-up now from the Cleopatra trial, and about 25% of people on Cleopatra are still on just this Herceptin potentially with the Perjeta antibody treatments without chemotherapy 8 years out. So it's actually not so rare. It's about 1/4 of the patients on that Cleopatra trial who are in that situation. We don't think, it looks like the longer people are on Herceptin, it doesn't really increase the risk of heart problems long term. We have people who have been on Herceptin for a decade or longer, and we don't think that that's a risk factor necessarily for more heart issues compared to, 8 years versus 10 years or whatnot. But I think the really interesting question that my colleague, Dr. Heather Parsons, is going to try to answer in a clinical trial is actually this question of, can people stop safely? So as an example, there's a type of leukemia called CML, or chronic myelogenous leukemia. And it used to be that people started on this, what was considered a miracle medicine, Gleevec, and then the leukemia melted away, and then we just left people on it lifelong. And they, Gleevec has more side effects than Herceptin does. And then these very brave patients enrolled on a very courageous clinical trial where actually it stopped. They stopped their Gleevec in that case. And about 60% of the leukemia patients 5 years later were essentially cured of leukemia. And we just didn't know it. We had been continuing everybody on this. So Dr. Parsons actually is hoping to launch a trial where people who are in this situation actually stop Herceptin and are followed every 3 months with scans. And we do blood tests, and we try to figure out whether there's a group of patients who actually can stop. That'll be exciting.
A really important question to ask and answer. So we'll be looking forward to hearing more about that trial. There are a couple of questions about Trodelvy, the newer medicine that you mentioned that had been recently approved. Can you talk, please, about why it's used in later line treatment, whether it's possible to get it as an earlier line therapy in triple-negative breast cancer?
Right. So Trodelvy, again, is this new drug that was approved, and the way the trial was conducted is that actually took patients who had at least 2 previous chemos for their metastatic breast cancer, and then people were randomly assigned to get Trodelvy or regular chemo, and the people who got Trodelvy did have higher response rates, tumor shrinkage rates, and lived longer. So it was given a regular FDA approval. There is a lot of interest in moving up Trodelvy and not waiting until that 3rd chemo. We have a clinical trial open at Dana-Farber where people receive either Trodelvy or Trodelvy plus immunotherapy, and we're trying to understand whether, replacing regular chemo with Trodelvy, and then whether there's a role for immunotherapy. And there are other places that are doing similar trials of kind of moving Trodelvy up a little bit. There are some situations outside of a clinical trial I will move up Trodelvy. So, there are patients who might have gotten AC and Taxol and Xeloda as part of their early stage breast cancer treatment, and within a year the cancer has come back. And that's a situation where I might actually reach for Trodelvy earlier than the current FDA, approval. But for most other patients, I'm at least using one other chemotherapy first. But I think certainly there is a lot of interest in understanding whether it makes sense to just bring it all the way forward.
Thanks for responding to that. There are a number of questions from people with different subtypes of metastatic disease about what would make a cancer change status between progression. So why would hormone receptors between biopsies change from being estrogen receptor positive to estrogen receptor negative? Can you please speak to that?
Yeah, it's a really good question. Some of it is probably related to cancers not being sort of a little bit of a mix in the first place. Some of it probably has to do with the way you do a biopsy, which is you don't look at every single cancer cell in your body when you do a biopsy. And some of it is actually it really is change over time. So just taking a couple situations, for people who have estrogen positive breast cancer, probably about 15% of the time at least, over time if we do biopsies, the estrogen receptor goes from positive to negative. And when that happens, it's important to know, because we have a good idea at that point that giving more hormonal therapy is not going to work. We don't fully understand why that is. Some of it may be that the hormone receptor positive breast cancers are better treated with the treatments that a patient got before, and what's able to grow out is the hormone receptor negative cancer. HER2 is something that is a little bit more stable. So there is less kind of gain of HER2 positivity. The place that we probably see it the most often, actually, strangely enough, is in the brain. And so if somebody has brain surgery for a brain met, I always retest estrogen, progesterone, and HER2 because it can change. It would change the treatment. And then triple negative is probably the most stable. So if you start out with triple negative breast cancer, it's not so common that it's going to become estrogen positive or become HER2 positive.
Thank you, Dr. Lin. We have a couple of questions about androgen positive breast cancer. Can you speak to when that happens and whether the androgen receptor can be targeted in metastatic disease?
Yes. So the androgen receptor is essentially the testosterone receptor, and it actually is present in all three subtypes of breast cancer. In estrogen receptor positive breast cancer, about 80% are actually androgen receptor positive. In triple negative breast cancer, it depends on the way you test for the androgen receptor, but anywhere between 10 to 40% are androgen receptor positive, just because we haven't agreed on how to do the testing. And there are clinical trials that have been completed and that are planned that are looking at basically sort of like prostate cancer medications, so medicines that target the testosterone receptor in people who have triple negative androgen receptor positive breast cancer. Some of the trials that have come out already have shown that at least some people have disease stabilization. There are not a lot of tumor shrinkages that have been seen. And so the next series of trials has been to try to better select patients and also tweak the type of androgen treatment or androgen blocking treatment to try to make it better. And then in estrogen receptor positive breast cancer, there have been some studies, not all blocking the androgen receptor. Some of them actually stimulate the androgen receptor, and those studies have also shown some people who have, again, not so much tumor shrinkage, but a decent proportion of people whose cancers stabilize. So there's a lot of research in this area.
Thank you. We have a couple of questions about eligibility for clinical trials. So one is about the washout period if you have brain mets. And I know that brain mets is an area of research interest for you. If you could speak to that, please.
Right. So, still the majority of clinical trials do not include patients who have what we call active brain mets, meaning something that is new, something that is worsening, that you have not yet had radiation treatment for. That is changing, and there are some trials that include patients who have active brain mets, but most clinical trials still include patients who have treated brain mets. But the washout period has gotten shorter and shorter. So, even 3 years ago, if a trial included patients with stable brain mets, they said it had to be stable at least 3 to 6 months, and it's a really long time. Nowadays, many trials are, some of them allow 4 weeks stable, and some even allow you to get radiation treatment and then go on a week later. So just because you have brain mets, I would not assume that you can't qualify for clinical trials. I think the eligibility has gotten a little bit easier over time.
It is exciting to see that more people with brain mets can participate in clinical trials. And there's actually another question, since you mentioned radiation therapy, about the role of radiation treatment in the treatment of metastatic breast cancer. Is it for palliation, or is it also considered a way to cure particular areas of disease?
Yeah, it's mostly for palliation with a couple of exceptions. The situations where we would very commonly give radiation are areas of cancer in the brain. So we commonly give either focused radiation or a little less commonly nowadays, whole brain radiation. In somebody who has an area of cancer that hurts a lot, like in a bone that is, especially like in the hip bone or some part of your body that bears weight, we will often give radiation because it works fast. It relieves the pain fast. But we don't expect that to cure somebody's disease. There are some studies that, they're not definitive, but some studies that have suggested that people who have what we call oligometastatic disease, meaning like one bone has a metastasis or two areas have a metastasis, that potentially giving focused radiation may improve survival. There aren't so many patients who fit those criteria because breast cancer tends to go to multiple places at a time. But, if you are somebody in that situation, it's certainly worth discussing with your doctor whether focused radiation approaches could be considered. I have to say, even in my very busy practice, I don't refer very many patients for that purpose of focused radiation each year. Most of the people who I refer for radiation are people where I'm really worried about a particular spot and I want to get symptom control quickly.
Thank you. So a couple of people are asking about the side effects of some of the newer treatments that have been approved, such as the CDK inhibitors, the PARP inhibitors.
Yep.
Can you speak to what some of the common side effects are of those treatments and how they're managed?
Yep. So for the CDK4/6 inhibitors, the two most common side effects are fatigue and low blood counts. The fatigue, obviously, people feel. The low blood counts typically are asymptomatic, and we find them on blood tests, but people don't necessarily feel them. The fatigue is very dose related. So typically, if somebody has fatigue at the highest dose of a CDK4/6 inhibitor, if you just back off on the dose a little bit, the fatigue does get better. And there have been some limited trials, especially with Ibrance, for example, where backing off on the dose doesn't look like it affects the effectiveness at all. So I feel very comfortable doing that. And then with the blood counts, really, I don't like to give growth factor with CDK4/6 inhibitor because it's an oral medicine you're taking every day. So I really just adjust the dose, and the blood count issues usually get better. It's interesting, actually, when the blood counts are low with CDK4/6 inhibitors, people are not as prone to infection as with chemo. It's a different, the white cells actually still work pretty well. With PARP inhibitors, the most common side effect is blood count issues again. And so that's the most common reason that we end up reducing the dose. And they typically don't cause a lot of hair loss, nor do the CDK4/6 inhibitors. Some hair thinning we can see. And some nausea, but it's usually not a prominent side effect. The newer antibody drug conjugates, whether it's Enhertu or Trodelvy, I think those really do feel more like chemotherapy. And in the original clinical trials, the way people were dosed is they got a dose of the medicine with sort of ordinary anti-nausea medicines. And then if they had significant nausea, they got, superpowered anti-nausea medicines. And so that's the way that a lot of places prescribe it, because that's what was done on the trial. But from my perspective, if we know that there's a high rate of nausea and vomiting, I personally medicate people with anti-nausea medicines kind of at a more maximal level from cycle 1, rather than doing medium level, waiting for nausea and then trying to, add back. Because I find that the nausea and vomiting and the GI side effects can be pretty prominent. And if we just get on top of them from cycle 1, I think people do a lot better.
Thank you.
Like all chemos, they cause low blood counts and things like that. But I think the nausea and vomiting sometimes take people by surprise.
Sure. Well, actually, while we're talking about blood counts, we have a number of questions from folks asking about the COVID vaccine and whether it is safe for people with metastatic breast cancer to get the COVID vaccine.
Yeah. So the short answer is, I think it is safe, and I would recommend people get it when it's offered. We do have some data. It's not consistent, but there is some data that people with cancer getting active treatment are at higher risk of COVID complications. So that even age for age, even a young woman with metastatic breast cancer getting chemotherapy is at higher risk of having more serious complications from COVID than a similarly aged person who's not on chemo. So I think from a risk-benefit ratio, I would recommend people get the vaccine. And I don't think, if we look at other vaccines like the flu vaccine, we don't see any worse side effects in cancer patients compared to people without cancer. I think that the question that we don't have as good of an answer to, because people on chemotherapy were not included in the trials that, for the Pfizer trial, for example, that led to the recent FDA emergency use authorization, did not include patients getting chemotherapy. And so if you were to ask, is it going to be as effective as somebody who's not getting chemo? The answer is, I don't know. It's possible it will be equally effective, and it's possible to be a bit less effective. We know the flu vaccine is effective in patients getting regular chemo. So my hope is the COVID vaccine will be fine and will be effective. I think that for those who are advocates, advocating for specific trials for cancer patients on chemotherapy, I think is important because this is a really good question. It's a question going to come up, and you kind of want to know whether you have the same protection as somebody who's not getting chemo, because you want to know how to live your life post-vaccine. But I think, again, short answer is I will recommend that my patients get the COVID vaccine. I'm looking forward to a time when people will be able to get it. I think in most of us are thinking that probably people with cancer on chemotherapy will probably be in the second wave, and probably vaccinations will be able to begin sometime in February is our hope. And that we can get through that second wave sometime between February and May.
Thank you so much, Dr. Lin, for addressing that. And we will be doing more coverage on this issue at lbbc.org, because we know it's an area that requires study and where we're still trying to find the answers to these questions. So just to reassure everyone, we'll still have more information about as time goes on. And we're very fortunate Dr. Lin's agreed to stay with us for a little bit while longer, so we're going to keep trying to answer your questions. So moving on to our next question. One of our participants has triple positive disease and wants to know, in terms of selecting treatment, is there a priority for starting with targeting HER2 or ER paths, or a combination, or something else?
Yeah. So for estrogen receptor positive, HER2 positive breast cancer, we really focus on the HER2 as that initial part of the treatment. So even somebody who is estrogen positive, HER2 positive breast cancer, we typically start with chemotherapy plus Herceptin plus Perjeta. But where the estrogen receptor positive comes in is that when we are ready to drop the chemo, which we typically do after a couple months, and we have people on Herceptin or Herceptin plus Perjeta maintenance treatment, then we add back in the hormonal treatment. We don't have definitive data that it helps people stay off chemo longer, but our sense is it does. And there are data actually in patients who, for whatever reason, we don't want to give them chemotherapy. They might be older, maybe they don't have a lot of disease, that the combination of Herceptin, Perjeta, and hormonal therapy, or Herceptin, Lapatinib, and hormonal therapy, that these sort of non-chemo combinations can be effective. But because chemo plus Herceptin plus Perjeta, for example, as the first treatment is more effective, that's usually what we go with first. But we definitely add in the hormones as when people are on this sort of maintenance phase.
Thank you. And our next question is about immunotherapy. The FDA recently, a couple of months ago, I believe, approved use of Keytruda in all types of solid tumors with a particular characteristic. And this person is asking whether this will come into play in metastatic breast cancer. Yep.
So there's what's called a tumor agnostic approval, meaning that it doesn't matter what kind of cancer you have. If your cancer has this certain characteristic, you can use the drug. And one of the examples is of a characteristic called mismatch repair. And it's essentially this way that it's a way that cancers are able to or not able to repair DNA damage. And there's a characteristic finding when you do the next generation sequencing or the genomic testing. And so that's there is an approval for pembrolizumab in the rare patients, like 1%. I mean, it's not very common of breast cancer patients. I have somebody who I'm treating in that situation myself. And pembrolizumab can be used in that situation without chemo, even just plain pembrolizumab. Similarly, there is a lot of interest in looking at tumors that have what's called a high tumor mutation burden. So that's the average number of mutations in the cancer, no matter what they are. And for people who have a high mutation burden, there is some evidence that immunotherapy, again, on its own without chemotherapy, can be effective. And there's actually efforts, including at Dana-Farber, to even build on that, so that there's a trial we have for high TMB patients where we give not only one immunotherapy, but for good measure, we give two together at the same time. And these values, the MSI, the sort of microsatellite stability or instability value, and the tumor mutation burden, the TMB, are now part of standard genomic testing. So if you have testing through a commercial company or if your hospital has its own homegrown test, they're typically reporting both of these values out.
Thank you. Our next question is about ESR1 mutations. What new therapies are being studied to target that mutation?
Right. So by way of background, ESR1 is the gene that codes for the estrogen receptor. And when it's mutated, the estrogen receptor actually can turn on and do all the things that it does without estrogen. So you can get rid of all the estrogen in your body if you have an estrogen receptor 1, ESR1 mutation. All the things that normally happen when you feed a cancer estrogen happen without estrogen. And so in that situation, we think medicines, for example, like Arimidex, which is designed to reduce the amount of estrogen in your body, are going to be less effective because the estrogen receptor can function anyways. So that's where this whole new group of medicines called SERD, S-E-R-D, or Protax, or Serons, there's all these sort of new hormonal therapies that are designed to get rid of the ESR1, the mutated estrogen receptor protein. Some of these are just starting out in phase 1 trials, but there are some already in phase 3 trials. And I think in the next couple of years, at least one of them is going to make it all the way through, and we may start being able to use them outside of clinical trials for people with ESR1 mutations.
Thank you. Our next question is from someone with lobular metastatic breast cancer. Are there differences in the treatment of metastatic disease based on the lobular status versus the more common ductal status? Yeah.
So I think for right now, the treatment is generally similar, although there's a couple differences I'll get into. One of the differences also has to do with how lobular breast cancer spreads, which is it often has a different pattern. It can show up actually around the outside lining of the bowel or as fluid in the belly. There's sort of a slightly different way that lobular breast cancer can show up, and sometimes it can be harder to see on scans. So sometimes the treatment differs just because we have to do different things related to the symptoms that lobular breast cancer causes. We do know that there are, again, we talked about this rare mutations in the HER2 gene, and we know they're actually a little more common in people with lobular breast cancer. So in a non-lobular ductal patient, the frequency is about 1.5%, 1.5 to 2% is quite low. It's about double that in people with lobular cancer. So still low, it's like 4 to 5%. But it's higher, and that 4 to 5% is 1 out of 20 people with lobular breast cancer may have a HER2 mutation, and so that opens up this this clinical trial that's looking at HER2 treatments because most lobular cancers are HER2 negative.
Thanks, Dr. Lin. So I want to ask this question: can you help us understand if metastatic breast cancer is constantly mutating and changing? Then why could you not receive the same treatment that you received in the past if the cancer has changed? Yeah,
that's a good question. Most of the time, as you, the questioner sort of recognizes, once a treatment stops working, we sort of abandon it and we don't go back to it. The exception is HER2 positive breast cancer, where we go back to Herceptin all the time. In general, our thinking is that once a cancer has become resistant, whatever is sort of growing out is the cancer that has not responded to whatever a patient was on. So if something grew on Xeloda, we assume that whatever grew is not responsive to Xeloda. I generally don't go back. There are times I might go back. And it's sort of a discussion with the patient, like if there's a better option, we'll obviously use the better option. But there are sometimes when, we look back at someone's history and they say, actually the thing that worked the best was that you were 2 years on drug X. And now we've tried 5 other things and they haven't worked. you might go back to drug X and see if it works again. And I do that sometimes. I wouldn't say that I do it in every patient, but there are some situations where I might go back to the same drug. I might go back to a CDK4/6 inhibitor, that sort of thing.
Thanks, Dr. Lin. And this, unfortunately, is going to have to be our last question, but I think it's a really important one. Has the COVID-19 pandemic stopped research into metastatic breast cancer? What can we do?
Yeah, it's a really good question. What I will say is that in the spring in Boston, we did shut a lot of research down, unfortunately. We still kept a couple clinical trials open. Anyone who was on a trial, we kept on that trial. We didn't stop their treatment, but we couldn't open new trials. And we sent a lot of our tumor specimens to the Broad Institute to sequence for research, and they turned into a COVID testing operation and had to regroup. That's all gotten better, so now the research is going on full steam. And so from the standpoint of our trials and our lab-based research, we have been able to do it. There's like social distancing that we've been able to institute even in the labs and things like that. I think that the place that we're going to see the most impact, unfortunately, is in clinical trial accrual. Because pre-COVID, our group would routinely see people from all over the country who were going to fly in for clinical trials or who were going to drive from a distance, take a train. And that has really gone down with COVID. And unfortunately, when we think about, how long it takes for a drug to get approved by the FDA, one of the big rate limiting steps is how long it takes to recruit to the trial, because you can't get the trial result until you recruit enough patients to treat and then follow. And so, I think that at the same time, what COVID has done is created by necessity some flexibility in clinical trials. So we have some clinical trials where the rules were before, like every part of the trial had to be done in Boston. And now we have some of the trials where we're allowed to do video, visits with patients, and then we ship them the study drug and they get their labs at home. And we were never able to do that before. And I hope that some of those changes that have come out of necessity will survive COVID because patients really like it. And it's really, I think, really important for access to clinical trials to not require people to come to the study site, every week for things that they could do at home. I think the things to do to help really are, whatever we can do to get the word out and to encourage people to still think about clinical trials in this very complicated time, is going to be the most impactful as far as getting drugs to approval. Phase 3 trial will never get an answer until enough people enroll that we can get to an answer. And if the enrollment slows by 50%, the timeline pushes out quite a bit.
Thanks for addressing that, Doctor. I'm sorry, go ahead.
But I was going to say, but I do want to reassure people, like the research is going full steam ahead. We have, in fact, I think because we're not traveling as much to all these different meetings and we're finding ways to do things by Zoom, that in some cases, people have actually been able to accomplish more, even with kids running around and all the crazy distractions. So, I think the research is definitely still going strong and people are incredibly committed. But the thing I worry about the most is the trial accrual.
Thanks for responding to that, Dr. Lin. And I'm really hopeful that we will also, in addition to carrying the lessons forward that we've learned, that there are some things that we can learn from the trials we conducted in the vaccine itself about the speed and the energy and the resources we can put behind clinical trials that may benefit our community of people with metastatic breast cancer.
That's exactly. I mean, people often ask me, what do you think about the speed of the vaccine? It seems like it was so fast, and is it okay that it was so fast? And, a huge part of why it was so fast is it was recruited so fast. So the example I like to give is, some of these companies recruited 30 or 40,000 people in less than 6 months. And that's how we get the results so fast. And if you look at a typical trial for phase 3 trial for metastatic breast cancer, it might have 400 to 600 patients and take 3 years to enroll. And, if it takes 3 years to enroll, it'll be at least 4 to 5 years before we see results. And that's, you know, and if you imagine, like, if we enrolled the COVID trials, the vaccine trials at the rate we enroll metastatic breast cancer trials, we'd be waiting a really long time.
Well, thank you so much, Dr. Lynn. I really can't thank you enough. You are amazing.